So the title of my talk is a metastructural model of psychopathology, integrating axis 1, axis 2, and pathological trait models. And my interest here is talking about how personality and psychopathology relate to each other on a very general basis. I chose to use axis 1 and 2 here because, as I hear, they're going out of style. And this seems like the last talk I'd get to use them in. So for old time's sake. This isn't really making it much quicker, is it? Anyway, the notion that personality and psychopathology are related to each other in important ways, and in fact that psychopathology may be a representation of personality or directly linked to it, is not mine, certainly, and it goes back to a very old literature at the turn of last century and even before it, and early analytic thinkers like Freud and Horney suggested that psychopathology was, in fact, issues related to personality. These days, understanding how these two relate to each other on the surface might seem very difficult in the sense that when we talk about personality, we talk about a broad individual difference models associated with personality traits, and there's now support for things like the 5-factor model, which is really the sort of the dominant model in basic personality science these days. And the 5 broad factors, I think most here are familiar with them, are extroversion as opposed to introversion, agreeableness versus antagonism, conscientiousness, neuroticism or negative affectivity, and openness to experiences. And now these are go by various names, and there are models that vary slightly in terms of how many of these factors they represent, but these are the ones that are sort of consensually and agreed upon across models, or can organize the models. In contrast to this, the DSM Source is our major compendium of contemporary psychopathology, and uses a very different approach to understanding the way individuals differ. And it uses discrete categorical disorders that we've been hearing a lot about this past couple days. And these are organized based on putatively different defining features. So for example, there's a mood disorder section, there's an anxiety disorder section, there's a psychotic disorder section, and so on and so forth. And in this model, personality is explicitly treated as separate from a couple of standpoints. One, personality isn't directly in the model per se, but there are personality disorders, and these are treated as on a separate axis and treated as if these are separate and distinct from both each other and axis 1 disorders. But there is reason to believe that there may be ways to replicate to integrate these models. For one, you might have heard about personality disorders as having replicable personality trait profiles within the 5-factor model. And there's been a couple of meta-analytic studies that have looked at this in recent years. But there's also, what may be less familiar to folks here, is that the personality traits have just as strong relationship with axis 1 disorders. And so the relationship between personality disorders and personality traits is not privileged, and in fact it extends across the diagnostic manual. It also extends to physical health as well, which is interesting given the talk that we heard on pain. And what we know from the patterns of disorders is that the DSM model, there may be some issues with it related to it not actually really representing well the way patients actually are. So what we've heard a lot about this weekend has to do with the fact that there's extensive comorbidity. And Eric Plakin gave an excellent summary of how this actually plays out, that if a patient meets one diagnosis, it's more than likely than not that they're going to meet multiple diagnoses. And I think that this poses challenges for clinicians. It's difficult to communicate from one to each other. You either end up with a long list of separate diagnoses, or you end up with things like NOS that aren't very specific. And it also makes it difficult to prioritize treatment. And you find that sometimes people want to treat the depression even if they're not treating, because they say that's the primary axis 1 disorder, even if the borderline personality disorder is present as well. It also poses large challenges for science. So we've heard a lot about trying to interpret findings from studies related to biomarkers and etiology and maintenance mechanisms in the disorder. But when the samples are heterogeneous, it becomes difficult to say what might be the actual causal mechanism. Which disorder is it? Is it the depression, or is it the borderline personality disorder, for example? But if you end up with a very clean sample that only has one diagnosis, then you lose external validity, and it doesn't actually represent the patients we all see in our consulting rooms. So there's that challenge. An alternative approach that's been gaining a lot of traction, I guess, in the past few years, or at least there's a larger number of studies being published related to it, uses statistical modeling to investigate the underlying structure underneath these patterns of comorbidity. So the suggestion there is that these things aren't occurring by random, and in fact, it has to do with their specific patterns of covariation. And across studies, there's a lot that have looked at this now. There's 3 replicable dimensions that emerge from if you analyze the patterns of covariation in psychiatric disorders. And these could include an internalizing domain or dimension that has to do with things like depression, GAD, panic disorder. These load on there. You have externalizing, which are substance abuse and antisocial and conduct disorder. And then you have psychosis or thought disorder that includes the psychotic disorders, but also things like schizotypal PD. But more recently, there's been some larger studies that have started to include other disorders, including the PDs. And when you include the PDs, there's 2 dimensions that haven't replicated well, but because there's only been 2 to 3 studies on this that have included full, access to in addition to these and these type of analyses. But you tend to find a factor that I might label as antagonism, as Roman Kotov did in 2011, where you have loadings from things like narcissistic, histrionic, paranoid, and BPD. And also pathological introversion has come out in a couple studies with things like schizoid and avoidant. So these are what some of these models look like for those of you who may be more graphically inclined. This is one of the early published study by Bob Kruger that shows that how these things look graphically. And the point, I don't want to spend a lot of time on these, but just to give you a sense of how this works. So the boxes are the actual disorders, and these circles are the latent factors that underlie these disorders, presumably. And those numbers have to do with the factor loading. So how much of the variance in that diagnosis is explained by the latent factor. And you can see that in some of these, they're hierarchical, and they start out with these basic internalizing, externalizing, and then you see they're getting a little bit more complex. Now they're including, when you're using it in clinical samples, where there's a high enough rate of psychosis to actually get a psychotic factor, you see that. And sometimes you need to let error covariances correlate in ways that make sense to make the models fit well. And here's the one published by Roman Kotov and co-authors, including Mark Zimmerman, who's going to speak to this later. Once you start including more disorders, you start to find more dimensions to explain these. So as I believe most in this room have been following, there was an effort to introduce personality traits into DSM-5, and they will be in DSM-5, but in Section 3 in the emerging models and measures section. And so the onus on us as researchers is to investigate what are their merits and demerits. And so this measure, there was a measure created for this personality inventory for the DSM-5. And it was an attempt to operationalize workgroup discussions on the characteristics of PD patients. And ultimately, they arrived at 25 fine-grained facets. One way to think about those is more it's more broader than the individual symptoms that you would think of in terms of the DSM-4 79 criteria. For PDs, they tend to be a little bit broader. And I'll show you what they are later. And when you look at this in terms of factor analytic studies, what has emerged was 5 domains that look very similar to the domains that you find in the basic science model and personality of the 5-factor model, or Big 5. And there have been a couple of other studies recently that are in press with Kate Thomas and colleagues and Whitney Gore and Tom Whittaker that have looked at this and shows that on a very general level this does converge with the model, other measures that are of the Big 5 from basic personality science. We also looked at the higher order structure in this, and we found that at the higher order levels, there are factors that emerge that look very close to internalizing and externalizing. And so this suggests that one thing that this could be is that this could serve as a way to start organizing psychopathology, or a way to integrate basic personality and psychopathology related to these broad dimensions. So in the current study, this is the very simple and basic question we hope to ask is, can broad personality dimensions serve as organizing domains for the metastructure? And the way we operationalize that is finding out whether the DSM diagnoses, including both Axis 1 and Axis 2, and the PID-5 can be integrated into the same model in a way that makes coherent sense. The sample is from Len Sims's CAT-PD study, 630 patients from mostly CMHCs in the Buffalo-Niagara area came in and were assessed. with clinical interviews and also completed the PID-5. Here are some demographic features of them. As you can see, it's a very broad and heterogeneous sample in terms of demographic features. In terms of the clinical features, just quickly to cover these, it's a sample with a lot of impairment and a lot of psychopathology. 2/3 of them met the criteria for one or more personality disorders. 60% met a criteria for a mood disorder, 63% for an anxiety disorder, and about 1/3 for substance use disorder of some type, and 12% for a psychotic disorder. There is no range there, because if you either met one, you couldn't meet multiple psychotic disorders. So the analytic plan for this, to show you that our data are orderly and come out in the way that they do in other samples, I'm first going to show you an exploratory factor analysis in just the axis 1 symptoms, to see if we get the 3 factors that you would expect: internalizing, externalizing, and psychosis or thought disorder. But then I'm going to include the axis 2 symptoms, and I'm showing this by themselves as well, because, like I said, this has been something that's been not done frequently. There's only a few studies that have looked at that. And then in the end, we use exploratory SEM to integrate axis 1, axis 2, and the PID-5. And exploratory SEM, for those who may be less familiar, is a way to do exploratory factor analysis, but also include other factors for things like method. And so in this case, we have a method factor for interview-based data and a method factor for self-report data. So we can partial out the variance that's associated with each of those and just look at the variance that's associated with the actual content of the scales. For those who are interested in modeling details, there are some of those right there. So in terms of model fit, and going through the first EFA, the best fitting model was the 3-factor model. You're looking for a non-significant RMSEA and a CFI that approaches or is greater than 0.95. Same for the TLI. And the TLI is a little low, but the RMSEA and the CFI are good, and 4 and 5-factor models would not converge. And what you see here, so on the right-hand side, you have a listing of the disorders. And we did this at the symptom level, meaning that these are dimensions of the disorders as opposed to just yes, no. And so that means for depression, for example, is 0 to 9 in terms of the 9 criteria of depression. And what you find is a very orderly set pattern with the internalizing or negative affectivity factor capturing most of the mood and anxiety disorders. Thought and psychosis. Now I split up psychosis into whether presence of hallucinations, presence of delusions, and presence of the negative symptoms associated with it. And the reason we did this is that you need multiple indicators in order to get a factor in this type of model. And ultimately you get alcohol and drugs. And there were some significant cross-loadings, but generally in ways that made sense. So for example, the internalizing and negative affectivity had a negative relationship with negative symptoms. So distress seems to be negatively related to affective flattening, for example, is one way to think about that. Now, in the combined axis 1 and axis 2 model, what we find here is that a 7-factor model is actually the best fit. And what you find is that you get distress, and you get fear, so that negative affectivity factor that was before kind of splits up. But we start pulling in some of the PDs here. So borderline is related to the distress factor, and we have avoidant and social phobia, panic, and agoraphobia, and dependent associated with fear. Substance use is also very narrow, just related to alcohol and drug diagnoses. And then you have an antisocial one, so that kind of separates out. Then you have thought and psychosis, and that includes schizotypal in addition to the hallucinations, delusions, and negative symptoms, but also social phobia, I think capturing some of that social withdrawal that you find in schizophrenic patients. And antagonism here, you see a lot of the PDs emerging on that, and it actually is a pretty broad antagonism factor, and that includes, in addition to the ones that Rome and Kotov found, things like schizotypal as well as dependent and obsessive PD. And ultimately, the last one is detachment and introversion, where we get the schizoid and avoidant loadings and also a negative loading from histrionic, right? So this is the other end of that spectrum. The histrionic items, or those symptoms really capture something that's not withdrawn. So the other way to do this is say, well, there's 7 factors here as opposed to 5 that you were telling us about. What's the deal? Another way to represent 7 factors like this is to represent it hierarchically. And as was shown in some of the other models, one way to do this is to fit a hierarchical 5-factor CFA, which also fits well, and have these be sort of more specific markers of those larger dimensions. Moving from there, though, into looking at how this all plays out in the including the PID-5. On the left-hand side of the screen, you see the specific scales related to the PID-5, so emotional ability, anxiety, so on and so forth. At the bottom, you have the thought disorder related items related to eccentricity, perceptual dysregulation, and unusual beliefs. And what you find that the loading on internalizing negative affectivity, it's actually a very broad factor and includes not only all of the disorders associated with internalizing, but those individual indicators on the other side related to anxiety, separation insecurity, submissiveness, depressivity, and so on and so forth. But it also pulls in some other stuff down here, including paranoid and schizotypal, borderline, avoidant, and dependent. All of these are going to have issues related to internalizing and distress, essentially. Externalizing and disconstraint now has markers, in addition to alcohol, drugs, and child and conduct and antisocial. It includes deceitfulness, hostility, not hostility, but impulsivity, responsibility, and risk-taking. These are the strongest loadings that are associated with scales meant to tap disconstraint in that regard. Thought disorder and psychosis, we see it also relates to sort of social withdrawal as well as the psychotic disorders and schizotypal. And we see that it also relates to eccentricity, perceptual dysregulation, unusual belief from the PID-5, but also anhedonia, so capturing some of that affective flattening as well. Here we see antagonism, it relating negative to agoraphobia, but paranoid, histrionic, and narcissistic are the strongest loadings on that side. And then we see on the PID-5, we see suspiciousness, attention-seeking, callousness, grandiosity, deceitfulness, and hostility. So scales related to antagonism. And finally, detachment and introversion. The only above 0.3 here are the negative loading on histrionic and schizoid. Avoidant just meets the cutoff. And then we have withdrawal, and intimacy avoidance, restricted affectivity, and it's a negative loading for attention-seeking and also callousness. So in many ways, this comes out in a very orderly fashion where across both types of measures, both the clinical interview and the self-report on the PID-5, we see these broad domains that cut across diagnoses in ways that make lots of conceptual sense. So in conclusion, I think that this suggests that psychiatric diagnoses and pathological traits can be organized within the same structure. And I think that one of the nice aspects of this from a scientific side of things is it allows for greater synthesis with basic personality science. And to the extent that there's a stronger link there, then we can have more access to a broader literature and better understanding of the ways that people differ in important ways. It also could help serve to guide decisions around how we want to go about assessing and diagnosing people in terms, I'm going to steal from John Oldham here a little bit, but he suggested that this, broad domains of this type could be used as sort of a psychiatric review of systems. And so I think that it's one way of organizing how we structure, how we think about these disorders. I think there's also some interesting aspects because when there's low loadings on a domain, it means there's potential for important heterogeneity in that domain for a given diagnosis. So for example, we recently published a study with Stephanie Stepp and Laurie Scott and Paul Poconis, where we looked at interpersonal heterogeneity in BPD, and what we find is that it's massively heterogeneous. And I think for all of you who do DBT work and who are used to sitting in a room and doing a skills study with 8 to 10 patients at a time, you look across the room and say, gosh, you guys all share a diagnosis, and at the same time you guys are all so very unique and very different in ways that are important for individual psychotherapy. I also think, because of time I'm not going to show it, but there is also unique variance in each of these things. Now this model predicts 73% of the variance in BPD. So we can predict the majority of BPD symptoms in this sample, which is really compelling. And at the same time, there's 27% not explained that's worth thinking about whether that is going to be useful or not to know about. So there's, I think the most useful level of the hierarchy likely varies for the purpose at which you might need it. And so while these might be able to help us organize research in certain ways, there might be times where it's maybe most important to know about the specific diagnosis. I also think what's interesting with this is that the interpersonal domains of personality really emerge when you introduce PD into the model. And I think that this helps show that interpersonal dysfunction really is the core of personality pathology. And I think that links up with a broad other literature on things like the interpersonal circumplex, going back to Harry Stack Sullivan's thinking. Future directions, I think there's a variety of places to go, but one way would be to extend this explicitly to normative traits and include normative trait measures as well as pathological trait measures. Like I mentioned before, are the residuals predictive of important outcomes or not? Looking at that seems, using this type of model, you can see if the residuals of a disorder predict something over and above the broad domain. That would be, I think, informative. And it would be also interesting to look at the hierarchical structure. So going both up and down. Here I talk about higher order factors that are known to exist above the big five, but there might be, what is the appropriate level? Like I said, there may be lower order factors that are worth knowing about. As you saw, drug abuse and conduct disorder do separate out a little bit within that externalizing factor. Thank you.